Good morning, everybody. It's so lovely to be able to have another TIFF conference, unfortunately virtual yet again. I will be sharing this chair with Miss Julie. Unfortunately, Elena Milona was very lately unable to be the chair as she should have been, but she sends her best regards. Miss Julie, are you near me? Okay, I will, well, basically, I would like to start by introducing the first speaker. Unfortunately, it's me. So we will go to the first speaker. Good morning, everybody. So, are we near achieving optimal treatment in the EU? Well, there are certain prerequisites for effective clinical management of thalassemia. Of course, is a dedicated area or clinic within the pediatric hematology department in the hospital. The next one, of course, is blood transfusion services to provide adequate supply and safe with appropriate storage. Ensure that the transfusion takes place in a safe, clinically controlled environment. And at a time that does not interfere with education work of the patients, if you want to actually have patients who can socially integrate. Iron chelation is the number 2 and most fundamental treatment for thalassemia. And it must be continuous and uninterrupted availability of all 3 authorized and approved iron chelators. You must have clinical experts in managing on iron overload, tailored treatment to each patient's needs, which may be different. Support patients' adherence in order to make sure that the necessary results happen. And of course, standardized iron monitoring, regular ferritin measurements, and MRI of the heart or liver. Multidisciplinary care. Thalassemia is a condition which affects many of our organs, and therefore various specialties examine patients for early detection of complications and are coordinated with pediatric hematology teams responsible for the patient care. A single clinical record is fundamental in order to be able to be followed by all the different clinicians. And mutually agreed treatment decision should be the end result, where everybody together decides on the treatment plan of the patient. Reference centers, now that is something that is very, very necessary, because it has the ability, it must have the ability to provide expert diagnosis and patient's management, resulting in optimal care, according to, of course, international guidelines. It must be able to support patients in the smaller peripheral centers, which might not have the necessary infrastructure or the necessary clinical knowledge. They have well-designed spaces for patient treatment. In other words, it must be privacy and a medical consultation. Maintain a patient's registry is important in order for the ability to convince commissioners and policymakers of the need for better service. And of course, must be involved in teaching and research. Healthcare professionals' ongoing education is a fundamental part of that. So factors influencing countries' performance. Well, the size of the thalassemia population, and of course the annual thalassemia births, makes those 2 points together, indicate the size and the importance that the government will actually prioritize or not prioritize. We need to know that national health system and its strengths. Is the health system able to provide the proper treatment according to the guidelines of the country? The government policies and priorities, is there the political will for the treatment of the thalassemia patients? And the health professional knowledge, now that is fundamentally influencing the country's performance, because with that, what comes next is the ability of the patients to have a better survival rate and therefore more capable of actually pressurizing for better services. So in other words, an NGO, a strengthening, a strong NGO and patients' involvement in policy decision making make a tremendous difference. The level of immigration, of course, will indicate whether the country is going to need a lot more support by the medical system. And of course, culture and religion makes a big issue of what will happen in the future, how the policies are implemented. This is a very busy slide, and I do apologize for that. Basically, my intention is to try and indicate different groups of countries and the specific characteristics that they have together. The group A, we're talking about Cyprus, Greece, Italy, Turkey, where there is a high indigenous population of thalassemia. And under those countries, usually you tend to find government prioritization and national disease-specific programs. There is registers. And of course, there is fundamentally prevention in, programs which are working very well. In the group B, it is low prevalence indigenous population, such as Romania, Bulgaria, Portugal, Albania, where the disease-specific programs not nationally coordinated. And there is an absence of prevention program. There might be some patchy, but it's not very well organized. And of course, group C, it is where you have high immigration population, basically maybe even second or third or even fourth generations that have migrant population, for example, in the UK, France, Germany, and the Netherlands. Here you have a strong research activity. You have national coordinated programs with prevention, but unfortunately not in Germany or Netherlands. All these groups have very, very similar challenges regarding of whether they are group A, where they have government prioritization and a well implemented systems, right to the group D, where there is very, very little organization or disease-specific services for management. So achieving optimal treatment across the EU. According to me, there are 3 regions in Europe with distinct characteristics and challenges. Southern Europe, for example, Italy, Greece, and Cyprus, they have large thalassemia populations. The size of the thalassemia population determines political power in the indigenous population. They have the ability to influence many well-educated health professionals on hemoglobinopathy treatment. They have prevention, which prevention has become imperative due to cost and blood consumption, good social integration of patients, and good social support. In Western Europe, which is the next group, for example, France, Germany, and the UK, predominantly second and third and fourth generation, as I mentioned earlier, of migrant thalassemia population. There is strong NGOs, unfortunately not in Germany, and there's strong healthcare professionals with good social integration. There is unfortunately weak prevention policy, except in the UK, where there is a very well organized prevention policy. And the last group is the Northern Europe, which includes Austria, Sweden, and Denmark. These are a very small number of thalassemia patients, so no political power, predominantly a migrant thalassemia population, established or new, and patients not familiar with the national health system or social provisions, limited medical experience regarding thalassemia and sickle cell treatment is unfortunately not as well as it should be. And there's no support for social integration of patients into the society. And that's because, of course, there is a weak NGO in these countries. And finally, I would like to basically indicate that the Global Thalassemia Review 2021 has shown unmet needs are many and multiple and universal across the globe. huge inequalities are prominent within and across countries and regions. As you can see from my red line letters, unmet needs is in greater in 80% of the countries studied. So this is what is, so my final slide will actually indicate that this is a call for action by the different countries in order to make the provision of a service for thalassemia patients slightly better. And TIF is here to help for anything you like. Thank you for listening. Lovely. So we will move promptly on to the next presentation, which is we will move along now to, according to the program, to Al Taglubi. I do apologize for the pronunciation. Please, the floor is yours.
Greeting everybody. I am Isra Al-Taghloubi, thalassemia major from Iraq, and I am honored to be a part of this important global conference, sharing my views and experience on thalassemia healthcare in the Middle East, including a look at some of the difficulties faced by thalassemia patients, as well as the needs required to achieve optimal medical care in the Middle East. Middle East countries include Lebanon, Syria, Egypt, Iraq, Jordan, Saudi Arabia, Kuwait, Qatar, Bahrain, United Arab Emirates, Palestine, Oman, Yemen, Iran, Turkey, and Cyprus. The most populous countries in the region are Egypt, Iran, and Turkey, while Saudi Arabia is the largest Middle East country by area. The countries of the South Caucasus, Afghanistan, and Pakistan are occasionally included in the definition of Middle East in some articles. What does optimal healthcare mean? Providing optimal care and services mean that clinical practice and decision making while meeting the needs of individual patient is effective, reliable, and safe. National, state, and professional organization establish standard and requirement based on evidence of best, best, best practices. It is a multidisciplinary activity. Thalassemia's need today is not like in the past limited on blood transfusion and chelating agent availability. For the time being, thalassemia patients need comprehensive health care. What needs are simple as leukoreduced blood transfusion and chelating agent availability, blood to be free, and no shortage in chelation. Constant periodic investigation, analysis, and equipment, availability of MRI to measure iron load, universal health coverage, no family out-of-pocket expenses, adequate trained health provider staff, adequate thalassemia specialist centers in the countries. We can divide the Arab country thalassemia according to the income. High income like Bahrain, Saudi, Kuwait, Oman, Qatar, Emirat, total thalassemia patients about 12,000. While other group, upper middle income like in Iraq, Jordan, Lebanon, total thalassemia patients are near 20,000 patients. Low middle income like Algeria, Egypt, Morocco, Palestine, Tunisia, total about 15,000 patients. Non-Arab countries in the Middle East, Iran is one of important. It's from low middle income, about 18,000 transfusion dependent thalassemia patients have. 2,000 non-transfusion dependent thalassemia patients, more in cities of Sistan and Baluchistan. Health expenditure per capita in dollar. The huge inequality in wealth is reflected in the quality of services for hemoglobin disorder. The less expenditure on health leaves many other priorities issue unsolved. Infectious disease, poor services for other conditions. So chronic disease are left for future development, which never comes. Healthcare coverage. In a lifelong disorder like thalassemia with many demand on resources, family or state, out-of-pocket expenses result either in suboptimal treatment and monitoring, family debt or bankruptcy, gross inequality in care. Universal coverage, no out-of-pocket expenses. In high-income group is perfect offer. In upper middle income, one-third offer universal coverage. In lower middle group countries is zero. May offer free basic treatment but limited scope of services. About prevention services, according to TIP judgment, in high-income group, three countries in B grade, three countries in C grade. In upper middle income group, two countries in B grade, one country in C grade. In lower middle income group, A grade, one country, which is Palestine, perfect. And one country in C grade and three countries in D grade. A grade mean countries with a program that demonstrate a very good effectiveness reflect in equal on the more in 70% reduction the annual affected births. B mean good effectiveness but no sufficient reduction in affected births, but with a good potential to upgrade its program to category A with targeted improvement. C grade, a program with some disease-specific policies, but with no national coordination and with weak to poor effectiveness, serious weakness, D, gaps and challenges calling for many and multiple action to be taken at the national level for effectiveness. Blood donation. Most of countries rely on replacement donation. Availability of MRI to measure iron load. Of 14 Arab countries, 6 provide MRI monitoring, 4 have limited access, 4 don't provide services. Quality of services, multidisciplinary care. 3 over 14 claim to provide multidisciplinary care. 2 claim limited services, and 9 is none. A national registry of patients, 3 over 14 maintain a registry in Emirat, Oman, Saudi, and Lebanon. Patient involvement, active in association and in advocacy, 3 countries, Lebanon, Emirat, and Palestine. What challenges we have? The recent population movement had led to a steady increase of career and patient in the Middle East countries. Middle East region in particular have suffered from scourge of poverty, displacement, wars and sectarian conflicts cause a shortage in health sector. Brain drain cause decrease in health staff, economic crisis cause financial hardship, education and job chances to the patient is low. So unmet or met this conclusion when we saw prevention in most of these countries is offered too few and so ineffective as a measure. Still, there is unsafe blood and poor relation in some cities. Still, there is a city's lack of thalassemia care center. Still, there is neither luspatercept nor zintiligor gene therapy available on trying or trying to strive with them. Still, there is shortage in supplies. Still, there high cost bone marrow transplantation. Still, there is a paucity of disease knowledge. Thank you for listening with wishes of health and safety to all.
Thank you very much for a very thorough analysis of the country's situation. May I remind everybody that you can put your questions in the Q&A section so that we can go to them when everybody's presentation has happened. Okay, so we move on to the next speaker, which is Viraj Piplani. He is a thalassemia patient and advocate from an advocate group in India. Please go ahead.
Hello everyone, this is Viresh from India, and today we're going to talk about challenges and unmet needs from the patient's perspective. So first of all, I would like to tell you a brief about myself. I'm a software professional working in a leading MNC for multiple global clients. I'm a member of Thalassemia Patients Advocacy Group India, TPAG TIF, and executive member of Thalassemics India. I would like to briefly introduce you to the topic that how the data looks like in our country, and it will reflect the overall how it is in the Southeast Asia. So first of all, we are the largest number of thalassemia major children in the world, which is an alarming situation. There are about 100 to 150,000 thalassemia major and almost 42 million carriers of beta traits. This is based on the data of 2016 and it is ever increasing. So in 2017, the number must have increased many folds. Every year we have around 10 to 15,000 new thalassemia major born children, which again is a critical situation. So the problem is that there is still a lot of gaps and challenges, and I will be talking more about that in today's session. So I will focus on three key areas where we are working and facing several challenges. So first of all, I will cover prevention, where we have some national programs and we do campaigns through news and social media. Then my next point will be about the management, where we'll be talk about blood, chelators, and multidisciplinary treatment of the thalassemia major children. And in the last part, I will cover the cure and treatment. How is the availability and how we see the future with regard to these in India and other South Asian countries. So I will begin with the prevention part. So here, health is a state subject. So center creates policy, which should be adhered by the states and implement on their state level based on their own budgeting and priorities. And because of this, some states where thalassemia awareness is a priority, they work well on this area. But for some states, there are other high priorities, and often the thalassemia part is on the back seat, and a proper attention is not received for these awareness programs. There are no budgets or skills or focus. The budgeting for staff, equipments, and chemicals is not adequate to support the large population in this region. We have budget constraints, and because of this, lot of screening is required, as we have seen in the previous slide, that there is a large number and a big population screening is required, which requires a lot of budget, focus, enthusiasm, motivation from government organizations and societies. But still, there are some budgeting related gaps. Awareness campaigns are there on the news, social media. We keep publishing those on TV, newspapers, and there are people and experts talking about it. But since the reach is not happening to the masses on to the places which are remote or a smaller cities and towns, so there we need some more improvement and a reach to those parts of our country and overall Southeast Asia. Then there is a lack of genetic counseling, pre-marital counseling, and natal counseling for the people. So ideally, for genetic counseling, it should happen on school and college level. For the masses, it happens, but for smaller groups, and we are only able to cover a small part of it. Pre-marital counseling can happen at hospitals or licensing places where marriages are registered, but that area is still a place where not much progress is happening. And antenatal is before the birth of a child, the parent should be talked about the thalassemia and its consequences, so they can take the decisions based on knowledge rather than ignorance. Then another thing is there are no rules from the government side or strict regulation that there has to be a population screening or pre-marriage screening. If something like this is in place, then definitely we will be able to reduce the load of thalassemia major to a lot, so that our existing people can receive more help and the budget is kind of concentrated towards them. Then there is a definite need of having a mass awareness drive on the school and explaining them the risk of people who will be born with thalassemia, what is thalassemia carrier, and if they are a carrier or not, and what type of preventions they should take while choosing a partner and while going with having a baby. Then one more interesting area is monitoring of programs. It can be more effective, and whatever best practices are there and whatever are the challenge and learnings from this program should be shared across community on a common forum, so that other people who are going to run new campaigns can utilize from it, learn from it, and improve on it, and then run their own programs, and then they can also share their learnings and best practices on the forum. So that becomes improvement over time on what activities are happening. So it is happening on a smaller level, but definitely a platform is required where we can do it on a larger level. In recent times, due to COVID pandemic, a lot of budget and focus went into that from all the health organizations and NGOs, and it definitely impacted the awareness drive for thalassemia. Moving on to our next section, which is key challenges we are facing in management of thalassemia major people. So there are some centers in India which provides very good care, which is at par with the international standards, and we keep getting more knowledge from international societies, organization standards, and they are implemented here within a very short span of time, and it is given to the people. But the problem is the number of such transfusion centers and hospital is very small, and this facilities is accessible to a very small number of people. And again, the pricing is on a higher side with such centers. There is still a large number of people who are struggling and only receiving average or below average medical care because of the locations where they are and the medical facilities that are accessible to them. And medical facilities are mostly concentrated in major cities in India, and that is true for most of the South Asian region also. So people travel to those regions, and sometimes they get delayed, their HP drop because of 3-4 hour commute every 2 to 3 weeks. So that causes a problem in the compliance and creates complication in thalassemia patients. Then there is a lack of standardization and uniformity, which should be there. So there should be a rule that all the transfusion centers should conform to certain level of standards, so that everybody is getting a good standardized care. These standards are there by National Health Mission, which is a health ministry initiative, and if and WHO and other organizations and NGOs keep sharing those details with different centers, people, doctors, and experts. So on some places they are well received and adopted, but definitely there is a need to reach to more people and get a wider adoptance of these standards across the transfusion centers in the countries. Blood quality again is a major challenge, which is a basic need. Blood should be having a good quality. It should be safe and give the required benefits to the children. But some, we see that there are very limited centers which have net tested facilities. There are some facilities providing ELISA for taste testing as well, but many centers are still not on the up to the mark testing level to provide a safe blood. So that is definitely a big need for the current situation. And leukoreduced and leukoplated blood is also not available at all blood banks. So ideally, the thalassemia major should receive the components which they require so that they reduce the risk of various reactions and enhance their quality of life. Now with the COVID pandemic, the availability of blood became a major challenge. There was no blood available, and all the focus of our organization and other NGOs went towards arranging the blood, ferrying the donors to the hospital, ferrying the patients to the hospital because of all lockdowns and fear in people to go to the hospital to do the blood donation. And because of this change in focus in last couple of years, the focus on advocacy and policy areas took a backseat. It is in progress, and we had some good milestones in advocacy area as well, but definitely the focus shifted, and because of that we were not able to do what we have originally expected or targeted to achieve in this area. Availability and supply of chelators from government's organization is not regular, and sometimes the brands change, and some brands may have higher efficacy and some may have lower efficacy. So that reduce the compliance in the patients because of breaks or because of different brands which are not providing optimal chelation, and that causes health challenges among them based on higher iron level and impact on the organs. We are working to help as much as possible, but still there is a very big number, and because of that, the reach is not what it should be. Now, coming down to our last challenge in treatment is that now we see that there are several new therapies which are available globally, and they're getting launched to increase the duration of blood transfusion, and gene therapy to cure thalassemia permanently in the patients. But we see a delay in launching all these in India and Southeast Asia because they are expensive, and there's a mass, but still they're still far from us. And whenever they are launched, we are expecting the price to be very high, and because of high price, only limited people will be able to afford it. So companies may delay the launch till the research is more advanced and they're able to put it on a price which is more affordable for countries like India and other South Asian countries. And even on higher price or medium price, the accessibility will only be with the people who are having financial stability. So we definitely need some help from organizations, companies, and government to keep the prices optimized and cover them through insurance so that is accessible to everyone. Having insurance cover is also a challenge for majority of people because health insurance does not cover thalassemia. For everyone, there are some special situations and cases and terms and conditions. So this again is a challenge that it should reach to everyone. Next part is when we talk about India, it is very good when it comes to the knowledge and skill and education. Like there are many experts available in India, and they're going globally and doing a lot of research. But within India, the focus on research and innovation is very less. There is very less budget allocated. So if we take example, we were able to create a COVID vaccine indigenously when the time came, but this kind of motivation, effort, and awareness is required in the areas of thalassemia research, because we are the majority in the world. We can definitely do some research and find some therapies which can help us globally. So with that, I come to the end of my presentation. Thank you everyone for your time, and hope to talk to you more about our issues and discuss these with you in future.
Uh, George, can you allow me to say a few words?
Please do.
Yeah. First of all, my humble apologies. There was something wrong with my camera, so I could not join early. And where I was to introduce my speakers, you know, and especially my first speaker, George, and the second, and then Viresh from India. And I would just allow me to say a few words that, well, you know, uh, uh, we all know that you must have, George, told all the speakers about the time limit, and then the question answer session will be at the end, and they can put their question answers in the live question answer box, which is at the bottom of your screen. And we all know, I was to introduce George, my colleague at TIFF, and you all know him very well, but still I would like to say a few words about him. He has been one of the founding members of TIFF, and he has been an active member ever since. And currently he serves as the Assistant Secretary, as you all must be knowing. And his passion and commitment is well known to all of us. So, and second, I would like to say a few words about Viresh also. I'm sure that George has introduced him, but he's a very passionate patient advocate from India, and whose special love is blood safety. And now I think we'll move to the next speaker, which is F. Johri. And I have met her a number of times, and she's from Malaysia, and she's the Secretary of the Federation of Malaysia. And she has been very actively involved in all the progress and the work that has been accomplished in Malaysia. So I request Johri to continue with the start with the presentation, please.
A very good evening, ladies and gentlemen. First of all, I would like to thank Thalassemia International Federation for giving me this opportunity to be part of TIFF Conference 2021. I will present Malaysia as the West Pacific country on this topic, which is challenges and unmet needs, the patient perspective. Are we near achieving optimal care in West Pacific? Let me share you my slide. First of all, I will introduce myself. I'm Fazalina Johari. I'm a thalassemia patient, HBE beta thalassemia. I was diagnosed with thalassemia at the age of 6 months, and now I'm 39 years old, and I'm from Malaysia. Okay, Malaysia, we have 14 states with 3 federal territories. We have 32 million population, and according to Malaysian Thalassemia Registry, November 2020, we have 8,681 thalassemia patients in Malaysia. I will focus on a few issues. The first one is self-blood, which is leukodepleted and net tested blood. Leukodepleted and net tested blood are available in all centers in Malaysia, and net testing is done in National Blood Center in Kuala Lumpur. And leukodepletion for district hospital, they still use bedside filter, and for main hospital, they usually use pre-storage filter in blood bank. But there's some issue, which is adequate blood supply, especially during this pandemic time. Challenges instead with higher number of thalassemia. For example, in Malaysia, we have Sabah that have the highest number of thalassemia patients, about 1,800 thalassemia patients. And it's a bit difficult to supply blood in Sabah because during this pandemic time. Another one issue is freshness of blood. It varies from hospital to hospital. Some hospital they give a bit of blood more than 2 weeks, but most of hospital they're able to supply about 1 to 2 weeks from blood collection. That another next gonna be chelation. All IR chelation are subsidized by government since 2006, which is include deferral, deferriferon, and also deferasirox. But deferasirox priority is given to pediatric patients, and due to high cost, it used as second to third line in adult patient, and the number of patients restricted by hospital budget. So it all depends with budget. For iron chelation, there's some issue as well. First is desferal pump, because not all hospital can provide desferal pump. So the Thalassemia Society or NGO will help to get fund for thalassemia patient to get desferal pump. And also same thing goes to Thalasset. Not all center are provide Thalasset. Some of them still use butterfly. So the society will help to buy Thalasset for thalassemia patient. Daycare services. Mostly main hospital have daycare center, and the operation hour usually from Monday to Friday, only on during weekday from 8 a.m. to 5 p.m. office hours only. And for those don't have daycare, patient need to admit in the ward. MRI T2 star. T2 star facilities available at most government hospital. So far, we only have 2 states that do not provide T2 star. And most of patients, they do T2 star yearly, but in some center, they do every 2 years. And this facility are free of charge for if you're doing in government hospital. Other monitoring for thalassemia patient include serum creatine. Patient usually do it 3 to 6 monthly. Endocrine test 6 monthly to yearly. DEXA scan, but it's not available in all hospital. We do it yearly, some every 2 years. And multidisciplinary service, for example, liver, cardiac, obstetric available, but need to be seen in different department. So it's involved another department too. So the challenges that we face, the first, as I mentioned earlier, which is insufficient blood supply. I think it's not only happened in Malaysia, but it happened in all over the world. But it's getting worse during pandemic time. For example, Malaysia have EMCO lockdown last year, March 2020. And since that, Sabah, one of the states in Malaysia, they lost 45 thalassemia patients since March 2020 until present. So it's a bit sad because there's no blood supply. People are a bit worried to donate blood. So patients need to wait longer to have blood. Another issue is compliance. I can say we have everything. Everything is provided by government, but it's no use if patient don't want or not appreciate it. They're not compliant with the iron chelation itself. So it would be great if government give everything to you, but you use it at maximum level. So compliance issue is always a big issue for us. Another one is daycare operation hour. I mentioned earlier is during weekdays only and from 8 morning to 5 p.m. So it's a bit troublesome for those thalassemia patients that's working. Another issue is not another main point is that I want to highlight is patient support group. In Malaysia, we have Federation of Malaysian Thalassemia Society. Under Federation, we have 50 members, which is include the State Society and also the Hospital Club. Patient support group is a group of people with common experience and concern who provide emotional and moral support for one another. It's very important, to educate patient and family, which we can do motivation camp or conference. At the same time, we can share the illness experience, and the strong society, they can help the weak society, to raising public awareness, which is, I think, is still not good enough. And at the same time, patient support group can help the fundraising in order to provide medical device or equipment, for example, thalasset and respiral pump. So as a conclusion, thalassemia care in Malaysia improved a lot if you compare it 15 or 20 years ago. And thalassemia have a good quality of life. And the most important thing I can say is Malaysia government and Ministry of Health give support to thalassemia. They subsidize our treatment. Since 2006, they have my thalassemia registry since 2007, which is really important because from here, we know the numbers of thalassemia patients, and from here, we know how we want to distribute the facilities, the budget for thalassemia. And since 2016, Malaysian government and Ministry of Health, they have thalassemia screening program, which is compulsory to secondary student, which is age 16. They need to do thalassemia screening. So at least we know thalassemia status among our students. So it's all about quality of life and finding a happy balance between work, friends, and family. The most important thing is you have a quality of life no matter where you are. I know it's not all people will get same thing, and I can say that we are quite lucky in Malaysia that we have support from our government and also Ministry of Health. They subsidize our treatment, which is most of thalassemia patients out there really hope for that. And as a thalassemia patient, what I can say that, yeah, we appreciate that we have now, and we hope that other countries will get the same, the equal opportunity as what we get. Thank you.
Thank you very much, Ms. Johri. We now move to the next speaker, Riyad Albert, and he's from Canada. He has been a leading member of the Thalassemia Foundation of Canada for over 15 years. And he has a special interest and expertise in blood safety. Currently, Riyad has been serving Thalassemia International as his treasurer, and I know him personally for many, many years, and he's a true advocate for the thalassemia cause. I now invite Riyad, please, to give your presentation.
Hello, my name is Riyad Elbard, and I am a thalassemia patient from Toronto, Canada. I'm also the president of Thalassemia Foundation of Canada and treasurer of Thalassemia International Federation. I'm delighted to be with you today for the 15th International Conference on Thalassemia and Other Hemoglobinopathies and the 17th TIF Conference for Patients and Parents, which is hosted virtually from November 19th to the 21st. Today, I will be presenting on a question that we have on our mind, and it is whether we are nearing achieving optimal care in North America. So first, I would like to mention a few things about North America. It's the third largest continent, covering an area of 24,709,000 square kilometers. Population is estimated at 580 million, and countries include large masses of area, which is Canada, United States of America, and Mexico. And also there are numerous smaller states in Central America and in the Caribbean region. For the purpose of this presentation, I will be focusing on Canada and the United States. That's because there's a lack of information on thalassemia in the other countries. However, it is known that there are very few patients in Cuba and in Mexico. So I did reach out to a friend of mine, Laurice Levine, who's in the US, and she's an active advocate and somebody who's very vocal on social media on health reform. And I said to her, we need to do this presentation. I want to get your thoughts on this and what you know. So, and I did say to her, we have a great opportunity given the great resources and institutions, the medical and scientific research and the expertise that is available. Also, the access to new innovation therapies, including curative therapies and the disease enhancement drugs, are a huge challenge because we don't know how they will be covered. And at the same time, there are a lot of disparities for comprehensive and multidisciplinary care throughout the landscape. Laurice said to me in her reply, I agree with you. We have a great opportunity in North America, and really with the money, the resources, the expertise, we should be soaring. And why aren't we? What are the obstacles? What is holding us back and dragging us down? So we'll be trying to answer some of those questions as we go through this next few slides. So first, I would like to look at how much expenditures, to just give you a quantitative measure on the amount that's spent on healthcare, both in Canada and the US. The US spends the largest amount of money per person on healthcare, which is amounts on average of $10,966 per person per year. And that is an average of 40% higher than Switzerland, which is the next country in terms of high expenditures. And Switzerland is known to be very expensive with very high standards of living. Canada is somewhere in the middle at an amount of $5,418 on average per person per year. So that's just to give you an idea. Canada is somewhere in the middle here, and it spends almost comparatively, relatively amount to France and higher than what the UK spends. The US is way up there. It's very high. As you can see, Italy is somewhere a little bit lower, the average, and Mexico is way down, just to put things into perspective. Also in the US, if you don't have, most people have insurance, and if you don't have insurance, you're really out of luck. And that number has increased. Those uninsured has become about 10.9% according to 2019 data. Canada, as we know, covers a lot of medical treatment. We have universal health care program, but a lot of things are not covered. Additional services, you do need to require to buy medical insurance, supplementary medical insurance. And about 25 million out of the 37.5 million of Canadian citizens do have private insurance through their work usually. So what is working well for us? We have expert hematologists that are linked to medical, academic, and scientific and research institutions. We have centers of excellence in major cities, and advanced research on thalassemia and hemoglobinopathies, advanced diagnostic technologies such as the MRI, Ferris scan, and T2 Star to assess iron overload, as well as bone density and all other sorts of tests. Also, safe and adequate blood supply has not been an issue. We had a bit of shortages in the US experienced in some regions during the heights of the COVID pandemic season. Again, advanced blood transfusion facilities and the thalassemia clinics are all within a hospital setting, which is excellent. And there's also medical expertise on other health aspects related to thalassemia, such as cardiology, hepatology, endocrine, or other fertility, and anything that might be needed for thalassemia patients. All iron chelation therapies, medications are available. Feriprox has the new advanced formula, the improved dosage, which is only available in the US and hopefully soon will be approved in Canada. Reblozyl or luspatercept is being used, and it's showing improved patient outcomes, and many patients are very happy with it and has reduced the amount of blood transfusion requirements. Also, we've had successes of curative therapies, gene therapy, gene editing, stem cell, and bone marrow transplant in the US have shown tremendous successes. Also recently in Canada, we had about 2 or 3 cases of successes in gene therapy, and stem cell and bone marrow transplant has been going on for a long time with a lot of successes. And medications for thalassemia and other related complications are also available. For example, diabetes, cardiac complications, or anything else. All these drugs are available in the 2 countries. So what are the challenges? So in the US, they have a broken healthcare system. Spending surpasses the other industrialized nations, but reimbursement is an issue. A lot of those who are immigrants or new medical refugees, which affects, which is a lot of the newcomers of thalassemia patients, about 90%, 5% in Oakland fit in that category, and the coverage is very little. It's about 10% of the actual expenses that they pay. Politics play a major part, which you know, Obama created the Affordable Care Act, and Trump tried to get rid of it. So this has been always an issue in the US on who's running the government and what the coverage for those who don't have insurance looks like. Disparity is glaring. The pandemic has been an eye-opener on showing that people who are affected by it are usually the people of color and people who are immigrants, and that really fits into the thalassemia and sickle cell population, and that affects their living conditions as well. So the disparity is huge. Now, medical providers are overworked, and burnout in the US is an epidemic. So a lot of doctors work too hard and they get paid less than their counterparts. Other hematologists, do better. And doctors who treat cancer and cardiology or any other specialty get paid much more. Thalassemia and sickle cell don't bring in money, don't attract money. So transportation also sometimes contributes to disparity. There are patients who don't live in major cities and have to travel to hospitals, and a lot of the time that is a problem. And to get to expert centers becomes a huge issue. Also, all centers of specialty are not created equally. So some of the centers in the US don't transfuse their patients according to what is needed. For example, some of the non-transfusion dependent patients survive on hemoglobin of 6.5 or 6.7 pre-transfusion levels. And also the thalassemia, the transfusion dependent thalassemia patients, their hemoglobins are allowed to fall below 8 before transfusion, which is very low. However, the specialist and the Cooley's Anemia Foundation is always trying to work with the doctors and have the patients transfused at keeping an average of 10 or more hemoglobin before transfusion. The other thing is transition from pediatric to adult care. Most centers do not have this transition. There is one excellent model in the US, which is the Children's Hospital of LA, and that model is not available everywhere. There's no registry, which is appalling. There's no data on number of patients, breakdown of thalassemia mutations. Novel therapy and curative therapies are very costly, and we don't know if the gene therapy is going to be covered. It seems like it will be covered because the cost for lifetime treatment of a young patient would surpass that. So hopefully that will help in the case of making that argument. And in 1983, the Orphan Drug Act is being set in the US, but it's being pared down. It is essentially the reason for the boom in research. So basically, they're afraid that there will be cuts to this Orphan Drug Act, which is from 1983, and curative therapies might be endangered or not covered. So that's why there is a bit of a rush trying to get those treatments for thalassemia patients covered soon before the changes. Here's a look at the map of the US. You can see they have the specialty centers. Some of them are really superly excellent, especially the ones in Philadelphia, both at the Pennsylvania University Hospital, the Boston Children's, the CHOP, the Children's Hospital of Philadelphia, Cornell University, as well as Dr. Vichinsky's clinic in Oakland and the one in LA. Again, to look at Canada, Canada has a healthcare system that is delivered through and funded by 10 provinces and 3 territories. Basically, each province has its own healthcare system and each territory has its own. Approval of drugs, for example, is done through the Canadian, through Health Canada, and then it goes to Canadian Agency for Technologies and Health Assessment for recommendations on funding. So Health Canada approves the drug, says this drug is safe, you can use it, you can sell it. But then the Canadian Agency for Technology and Health Assessment says this drug should be covered or should not be covered. And following that decision, each province then will look at that recommendation and then decide if it wants to pay for that drug and how much of it do they want to cover, whether it's a percentage, full amount, or small amount, or nothing. Recently, we have something called the Patented Medicine Price Review Board, which is a newly established independent quasi-judicial body that is part of the health portfolio and operates at arm's length from the Minister of Health. Basically, this is to help negotiate pricing on new and expensive drugs. So this may drive away, we're afraid that this may drive away many of the manufacturers of new drugs and bring in and stops the bringing of new drugs into Canada or delay it. Also, the drug approval and funding coverage is a lengthy process. On average, drugs are approved by Health Canada 18 months after FDA approval, and coverage decisions are about another year, year and a half following that approval of the drug. So pediatric care is usually excellent. However, that is not the case for adult care. Transition from pediatric to adult care is not available at all centers and cities. We do have an excellent transition program that is a combined program for the Sick Kids Hospital and University Health Network, which is the adult hospital in Toronto. And it's, they have worked hard on developing and sustaining this excellent transition program. However, this program and the model of care is not practiced at all other centers, or maybe at just very few. Hematologists are overworked, similar to what we heard about the US, and hemoglobinopathy clinics are under-resourced compared to other hematology programs, such as hemophilia, or if we want to look at the malignancies, the cancer clinics. There are no designated clinics for small thalassemia patient populations. Those that have about 10 or less or slightly more patients, they don't have a specific program. They are usually linked to a cancer clinic or to some other blood disorder program. So this takes away the expertise, and then you don't have someone who's really an expert on thalassemia, and that significantly reduces the opportunity to enroll on research trials, because those hematologists are not interested to spend their time on a few patients with very little resources. Standardized care is not enforced, and the treatment varies across the country, and that's something that we've been struggling to try and achieve, and we are keeping our advocacy efforts moving forward on that, because it's extremely important to have standardized care. Again, lack of social workers and hence the support resources for the patients. So patients and their families must navigate on their own. If lucky, the help of the nurse coordinator and or the medical team might direct them into the appropriate resources. Access to medical supplies that are essential for Desferal infusion are not equitable and vary from hospital to hospital. Not all hospitals give you the same coverage for Desferal or subQ-sats or the pumps, anything that's related to using Desferal. And again, access to chelation therapy and the coverage of these drugs or other drugs that are important for thalassemia varies from province to province, and at times according to insurance or subsidies coverage, depending if you have insurance through work or not. Recently, an influx of immigration from the Middle East and Southeast Asia has increased significantly the number of thalassemia patients across Canada, and it also has distributed them into centers, into cities where we don't have thalassemia centers, and that's raising new concerns and around patients' needs, because they are newcomers, they are trying to settle. There are cultural barriers, there's language barriers, there is socioeconomic barriers, and it's a big challenge for the patients and the hospitals. And coverage for new therapies, including gene editing and disease enhancement drugs like Reblozyl are uncertain. We don't know if we will have full coverage or partial coverage and at what percentage we will be getting that. We hope that a national policy on drugs for rare diseases will address such needs and provide a clear pathway for such coverage. Here's a map of Canada. You can see these are the names of the cities where we have thalassemia centers, and I've marked Montreal, Toronto, Vancouver in red because this is where you would probably have very good care. Also, Hamilton has a clinic, but it's not very well organized. The other centers in those other cities also have like excellent hematologist expertise, but there's no designated program. Ottawa has also an excellent program for the children's at the Children's Hospital of Eastern Ontario, but the adult care is not really that great. In summary, what is available in Canada and the US? It's excellent quality expertise on thalassemia and other hemoglobinopathies. We're really lucky that we have great doctors and well-trained, excellent experts, world leader academic, scientific, medical institutions that provide great opportunities for research and medical advancements. We've been having a lot of great research taking place in both the US and Canada. Well-trained nurses and other healthcare providers, the teams you get at the hospital are excellent. There are also training programs for hemoglobinopathy and thalassemia-related medical disciplines. So this is really good in terms of training and preparing new doctors to get into the field. A breakthrough medical advancement, innovative and curative therapies and disease enhancement therapies, they are available. That does not mean they are accessible to everyone. Orchilation agents are available, safe and sustainable blood supply, well-resourced hospital. As I mentioned, they are great centers. However, thalassemia, hemoglobinopathy clinics are not all adequately resourced, even at some of the finest institutions. The gaps, comprehensive multidisciplinary care is not available for patients receiving care at smaller centers. There is a need to standardize care across North America. Adult care centers are not all adequately resourced. Transition of care from pediatric to adult care is only available at very few centers. The examples that I've given you, maybe another couple more like that. There is a need for an equitable and sustainable access to innovative and curative therapies. We need also disease enhancement drugs and access to chelation therapy and all other essential life-sustaining drugs. Psychosocial support, which is always under-resourced and it seems to be always ignored. Access to social workers, system navigators, and holistic support system. We need a support system for the patients because the burden of the disease is huge on the patient and the family. In conclusion, there's a great potential and the required resources are attainable to ensure optimal care for thalassemia patients throughout North America. What is available is not accessible to everyone. Disparity in care is a cruel reality that many patients experience. A stronger business case to access expensive drugs, curative therapies, and comprehensive care must be presented to key decision makers. We hope we can make this case and present it to the decision makers and preferably within a rare disease or hemoglobinopathies national policy. Patients and patient organizations must continue their collaboration of effort with all stakeholders, hopefully with our medical experts and the hospitals, on effective advocacy to achieve sustainable, timely, and equitable access to optimal care for thalassemia patients. Finally, I want to say thank you to Louise Levine. Louise has been great. She's an independent medical consultant. She has lived in many parts of the US, so she experienced getting treatment at various centers. She's vocal on healthcare reform, as I mentioned, and she is a patient advocate, and I appreciate all her help on this presentation. Thank you very much, and I'll be happy to take questions from any of you at any time during the discussion session. Thank you.
Thank you very, very much for a very concise and very accurate information of the North America situation. Now we move into our last presentation. It is from Merulla Sagali, Association for Thalassemia, and who has, according to my standards, revolutionized thalassemia in Latin America. Merulla, the floor is yours.
Hello, everyone. My name is Merulis Gigo. I live in Brazil. I am a thalassemia major patient, 55-year-old, and I'm very, very pleased to be able to share with you a little bit of the efforts of what we're doing in Brazil in order to support the thalassemia patients and to advance treatment, not only in our country, but in our region as well. So thank you for TIFF for the invitation. It's always a pleasure to collaborate with your efforts, and you know that you always can count on me and on us, on our team. So let's go to the presentation. I will be sharing with you my slides. I'm going to be speaking about Abrasta. Abrasta is the Brazilian Society for Thalassemia, and it was founded by a group of parents in 1982. And what we do, we have a lot of programs to disseminate knowledge about thalassemia. We have a very active medical scientific team and committee with national and international experts. We develop several programs that I will show you more details later on to support patients throughout their journey, not only with social, psychological, nutritional, and legal support. And we develop several campaigns and events in order to update patients with the treatment information, the family members, healthcare, and all the hematologists about the advancements in the treatments. Thalassemia is a very rare disease in Latin America. Only Brazil, Argentina, and Trinidad and Tobago have associations for patients with thalassemia in their country. And Brazil is the largest. It's located in South America. As you know, we are 212 million people in our country, and we are the biggest geographic extension in population and in area in Latin America. And we have, even if though we have such a big population, we only have 1,000 patients with thalassemia, more or less. This year we conducted a survey. We always do surveys with the patients to understand their unmet needs, and according to what the patient report us, then we can tackle and to address those unmet needs. And from the 632 patients that responded our questionnaires, have thalassemia major and 268 with thalassemia intermediate, but they received treatment in 88 treatment centers around the country. And from those 88 centers, 15 are the ones that have 75% of the patients have received treatment in only about 15 treatment centers. And then we have minor centers with smaller groups of patients being treated. And in order to understand in one picture how is the situation of the treatment in our country, we organized this slide. So what is easy access? What everybody has access, not most of everybody, 90% of the patients, they have access to easy to transfusion, blood transfusion with NACHI, with the filter, leukocyte filter, and also they have access to alkylators, destro, feriprox, and XJ, according to what the doctor will be prescribing. The access that is medium, not everybody has access, and it's still somehow troublesome is the infusion pump. It still is hard to buy, to achieve, and also to maintain. There is no assistance, easy assistance in our country. And sometimes, the exams, the control exams are also not accessible, unfortunately, to everybody. So to analyze the bone density, to analyze sometimes gynecological tests or other endocrinological exams. All of these exams are still not very easy for everybody. And also MRI, although MRI we had in Brazil accessible for many years for everybody through a project with a very big private hospital, but that was offering as a charity, let's say, program, and also as a clinical study program. They offered for many years the MRI for all patients, and this was very accessible. But unfortunately, the program stopped, and today, to do MRI in Brazil, only for those patients that have access to insurance, and from time to time, we are able to get some room for the patients in the public hospitals also to have the MRI done. And hard access still, I think, is a challenge, not only in Brazil, but internationally. The access to the labor market in order to be inclusive, to have job opportunities in big companies and be able to be, let's say, to develop a career in not only as an autonomous, because as autonomous you can go on and be by yourself, but if you depend to work for somebody, it's still very hard because of the discrimination and the little knowledge and the regulatory limitations to hire somebody with some disabilities. And well, having this picture in mind, what we are doing in order to improve the situation. We have, additionally to the office in São Paulo, we have chapters around the country. And these chapters allow us to be very close to the patients in the different treatment centers and be able to not only register the patients and also to be able to talk to the patients more frequently, but also be able to share with them our initiatives, our campaigns, our materials, so that they can also be always engaged and engage the health professionals in the different centers and the managers of the municipality and the government officials. So the programs that we develop to meet the unmet needs are basically in 4 pillars. We have information and education. And information and education is different formats that we develop: materials, folders, awareness campaigns, Info Abrasta, that is like a newsletter, and we address diagnosis, treatment, multidisciplinary care, voluntary blood donation, in medicine. Let me see. Sorry, man, the word. Complementary. It's not complementary therapies, but integrative care, other therapies that can be added to the regular treatments that can support a better quality of life, and several things that we share not only in our website, but we have a very active social media channel and several channels to be in touch always with the patient. As I said previously, once a year we conduct a survey to understand what's going on and what are the needs of the patients and what are the biggest challenges, how our programs help them and what do they need and so on. So this is very important to understand what our patients want. We have a very active and intense advocacy agenda. We participate in the National Council of the Ministry of Health. And as always, not only in Brazil, but in any country, the advocacy is something that you have to continuously do efforts, and the achievements are slowly. So slowly, one by one, we move on and we take the voice of the patients, we participate in the agenda, we show that the patients are growing, getting older, the challenges are changing, and well, this is important, and the government appreciates our participation, and it's really needed. So our team is always hand by hand with the government officials and the health professionals. On the other hand, in order to improve the treatments, not only the patient must have the information, but the health professional, and especially the physician, must be very well updated of what is the treatment news and what is happening about thalassemia and how to deal with all the multidisciplinary approach of the patient. So we have an online platform with courses for the patient, but I think this is something that I was supposed to talk later about that. But anyway, we have courses for health professionals, and I will show you later on a little bit about this program. And here we have patient services in our slide. And the patient services include lawyers, physicians, nutritionists, anything that the patient needs as a support throughout the treatment journey. Well, so as I said, the support for the patient is complete. We look not only at the social, psychological, nutritional, also religious, and also legal support, but also in terms of access to treatment. We try to solve the issues with MRI and so on. We talked about the chapters that we have in several cities. And here is a little bit about the work that we do with those chapters, visiting the hospitals to understand the general conditions of these treatment centers, talk to the health professionals, talk to the physicians, talk to the patients, and organize reports for the health ministry, and also make a plan together with the health center of how to improve assistance and bring more comfort to the patient and more efficacy to the treatments. Because of the challenge for job opportunities, we started this program together with a big educational group, giving scholarships for several training courses to improve opportunities in the job market. So, for example, a photographer, hairdresser, several courses that the patients can take and then be able to have more opportunities for their job and for their social inclusion. Campaigns. Campaigns is something that we love doing, awareness campaigns. And this is one of the campaigns we did this year for blood donation. And it was really, really interesting. So we were able to engage several authors, celebrities that they promoted in social media. The information, go out of home to do good, something like that. Go because everybody was inside the house, but we wanted people to go outside and donate blood. So the message was very nice and people really got engaged. And we were able to engage a company that is like Uber in Brazil, is the 99. They are a transportation company, and they were offering free transfer for the donors from the blood center, from their house to the blood center and back to their house. And so this permitted that more than 4,000 donors went to 35 different blood centers in different cities that the campaign was running. Also invited a graphic artist, and they did this very large graffiti painting asking people to donate blood. And this was, the train was passing, and this view is from the street, from the train station, but also from the avenue, you could see the message. And this was very successful. And because of the big engagement of celebrities, of the transportation company, of the graphic artists, we also got a lot of engagement with the media that announced the campaign. So this is an example of one of our campaigns. Also, we do awareness campaign during the Thalassemia Day, Thalassemia May 8th, and then we promote in Facebook, in Instagram, in Twitter, in our social media, this information, and always that creative, and we engage the media in our campaigns. The surveys I already mentioned. This was also a very interesting and innovative experience that we have, a program that we were able to collaborate with TIF and several other associations from England, from Canada, from US, from Argentina, in order to make this digital meeting for patients. And we are planning the second to be held in May 28th of 2022. So save the date. If you're a patient, you must join this meeting. It's an amazing digital meeting. No presentations. We just share our experience, our thoughts, our concerns. It's really a very socialized media event for socialize and share and get to know other patients around the world. So it's strategic, it promotes connection and reconnection among the patients from different countries allows the interaction and inspiration. So it's important. It's an opportunity to get to know other patients, how they live in the other countries, what are their challenges, what are the barriers. So you can ask me, I can ask you. And in this digital meeting, we have this time for us to talk and share among ourselves. Only patients are allowed. And the program is divided in 3 age groups. And so according if you're teenager, older or younger, there is a different room. And we have, each room has 3 languages. So you can also be speaking English, Spanish, or Portuguese, and you will be able to understand what everybody is saying. And additional to the sharing of experience and thoughts, we also have the opportunity for us patients to show our talents. So somebody that is singing, that is dancing, that is doing yoga or special sports, or is cooking, or is whatever talent the person has, dancing, they can record this talent, and during the digital meeting, we will be showing the videos of the talents received, and then there is a contest and voting, and with prizes for the most talented thalassemia patients. So if you have some hidden talent, start practicing, and in May 28, we want to share with our international patients community your video and your experience. So contact us and to learn more about this international digital meeting for patients, and let's work together in order to invite as many patients as we can reach for this next year. That will be our second meeting. So previously I already anticipated about the online course for physicians and health professionals. So this is a digital platform that is very, very recognized for cancer education. And we also have the thalassemia course in this platform. And so we are able to update physicians, hematologists with this training. It's 16 hours of update about the treatments from diagnosis and all the details of the treatment. We have international experts such as Alan Cohen, Dr. Piga, participating in this training. And it's very interesting because it's all recorded with very good quality, allows interactive conversation about the among the physicians that participate to discuss.
Okay, thank you very much, Marula, for your nice presentation. And it's a wonderful work that you have been doing it for so many years. Here, I would like to say a few words, a few comments about this unique session. You know, this session is unique in itself because we have all the 6 speakers who are thalassemics. So it is a great achievement in itself. And the all credit goes to all the support groups, the local support groups, and to their governments, and to Thalassemia International Federation, who has been so vocal and instrumental in teaching us and educating us how to bring us together. And there is another thing which I want to share here is that all this has happened over the years. Thalassemia is not a priority in any of the governments. So what has happened and what we have achieved it is all because we have worked hand in hand. Collaborations is very, very important. We do not have to stop here. because what you have heard here is some presentations from the most developed worlds, and still they have a lot of challenges. And we have heard the presentations from the developing countries where they have come a long way, but still there are unmet needs. So together we have to see in our coming sessions or maybe later on that how collectively we can work together and make sure and come to a stage where we can say in our next conference or maybe after 5 years or 10 years that we have achieved a lot, and we will do all that. To achieve that, we will all work together hand in hand. Over to George, my co-chairperson.
Yes, you're absolutely right, Ms. Lee. My comment on the whole presentation is that you have 6 people who are all thalassemia patients, but they are in the lead of changes in the treatment of thalassemia in their country and in their region. We do have one question which I will not say, because it has a medical, it's a medical question. Therefore, we're passing it on to the chief office to be answered by a doctor. I do have one question just to get everybody thinking. If money was no object, and you had one choice to change something in your country, only one thing, but no money problem, what will it be? Can anybody answer me, please? Let's start with Fazelena.
Okay, I think the most issue, it's not issue, but common things that people stigma toward us. I mean, like it still happen nowadays, and I think the main issue will be awareness, because people still don't have awareness what is thalassemia is all about. So some of them still look down on us, and I think that is what the only thing that really make me a bit sad and disappointed with people out there. So yeah, I guess that is the one issue that always keep bothering us as a thalassemia patient. Other people's stigma toward thalassemia patient.
Naresh?
Yeah, hi everyone. Thanks, George, for asking. So my one thing which I would focus more is awareness, that every single person should know what is thalassemia, how it happens, and how to prevent it. So in that way, all the get themselves tested in order to know their career status, how they are with their thalassemia trait or not. And second, they know that thalassemics need blood, so they themselves will come and donate blood for the cause. So awareness is one area where I will put like 90% votes. So that is one thing I would definitely want to have.
Merula? Merula, we can't hear you.
Let's see.
Merula?
Okay, can you hear me?
Yes, thank you.
Can you hear me now? Okay.
Yes.
So thank you, Mrs. Tooley, George, and Riyad, and everybody here in the room for this important session. I was in my last slide in my presentation. I was going to show the picture of my family in the next slide. So from all the projects that we have done in Brazil, for me, the most important was the building the family that I have. Today I have 3 children, one 27, one 23, and one 21-year-old. But these are the, so let's say, energy that gives me to keep going and follow their growth and so on. So I wanted, my last message in the slide was to keep the faith that you can do it. Nah? Build your family, build your career, and thalassemia is not a limitation, it's an opportunity to speed up your dreams. Yeah? Now, coming to your question, George, I think the one thing I would focus more the next couple of years is job opportunities. Job opportunities. Because people can have information. People can have awareness. Today with the internet, anybody can dial thalassemia and read and find out. So if they want to find information, how to treat, it was different when me and George, we were kids. Our parents had no story about how to treat thalassemia, what was right, what was wrong. Today we have treatment options, we have exams. So if we fight, it will be available for the patients. But job opportunities is something still very limiting. And when somebody wants to have a complete life, nah, and think about full development as a family, you must feel that you are inserted in the society. So I think despite we have a lot of campaigns about minorities, about inclusion, about so much, still the society is not prepared to receive in the job people with limitations because we're not
Yeah.
disabled. Nah? We have just limitations. So
Okay.
just to end, George, just to end, what is our, let's say, opportunity? Talk to the people, to the government that defines who are the disabled people, yeah? And those disabled people have gained across the years some rights for jobs and so on, and have a separate chapter about not disabled but special limitations, and for people like us that have special limitations but are completely able to develop and to do any type of activity that we want. We even have thalassemia pilots in England. Nah? So
Thank
you
you.
can do anything that you want.
Yeah, I'm sorry, we're running out of time. So the last comment, it's very interesting that I was waiting to hear that we want to make thalassemia transfusion better or chelation better or better MRIs, but instead what I'm hearing is we want to get socially integrated and people to stop having no knowledge of thalassemia. This is tremendously interesting. Thank you very much, everybody. Miss Julie, I think we are done with time or they will switch us off. Please say goodbye to everybody. Goodbye, everybody. Thank you very, very much.
Yeah.